All right, looks like we're about ready to get started. If Dr. Shapak or Angela, you want to kick it off?
Thank you so much. I'm going to go first this morning. Just quickly, let me introduce myself. I'm Angela Rigglesworth. I am a third grade teacher in Houston. I'm not going to lie. I really wish I was in California right now because that sounds like such a treat. So I'm a little bit sad that we're virtual, but I'm just thrilled to be presenting alongside my friend and colleague, Dr. Danielle Shapak, and she'll continue in a minute. We're going to start off. This idea of psychological wellness is obviously a huge topic that umbrellas so many subtopics. And so when we were kind of planning together, we decided that we would cover the things that we kind of feel that we are the resident experts of at this point in our lives. And so we'll talk about sexuality and disability, and then we'll go into the art of asking for help, and followed by some Q&A. So at any time, please feel free to type into the chat if you have a question, and we'll address those at the end. I'm going to start with this story. We always like an anecdotal story to begin and to kind of segue into a conversation. And so I'm going to help Danielle with a personal story segue into sexuality and disability. And that is my experience that I had as a young person in a very big decision that I had to make. And it was kind of had made for me in a way. I was a I was a junior at Texas A&M, and I was battling with having my period and really, really struggling with having another person take care of me other than my mom, and just all of the things that go along with a menstrual cycle. I had been on Depo-Provera for several years, which turns out was probably a huge mistake in regards to my calcium amount and as an adult later on. But I was bleeding through, and it was just horrible. Don't y'all love how I'm really getting into it right away? I'm just going for it. We're just talking about bleeding during our period right away. But it definitely
wake up.
That's right. It was definitely something that was so hard. And so in a conversation with my gynecologist, the decision, an opportunity was given to us to try a heat ablation. And at the time, it was a fairly new procedure. For those of you who are unaware, though I'm quite certain I'm speaking to medical professionals, so you know what an ablation is. But my doctor suggested that we do a hot water bag heat ablation and remove the lining of my uterus, so that I would no longer have any blood. I wouldn't be bleeding during my period, and obviously eliminate that stress in my life of having someone else care for me during that time. And so that sounds wonderful, right? Like to a 19-year-old who's thinking, yes, I won't have these kind of mortifying experiences anymore, of another 19-year-old caregiver helping me. And so I thought, definitely. And part of the conversation was me understanding what it meant to have the lining of my uterus removed, and that was that I wouldn't be able to have children. But in 1998, the internet wasn't really a thing in terms of knowing that there were other women across the country who had SMA type 2 like I did, who have successfully had children. And so I didn't really know that I would be able to carry children. And my mom, in her able-bodied kind of thinking mind, remembered what she went through as somebody who had a child and carried me to term, realizing the things that happened to her body, and in her mind thinking there's no way that I would be able to do what she did from a wheelchair, and given the circumstances of my body. And so with the advice of my doctor and the conversation with my parents, I decided to have the ablation. And um, I think that it was the right decision at the time for me, given the lack of information that we had. Um, However, it's something that I've certainly struggled with emotionally as I've continued into adulthood and met such amazing women who have carried children to term and are moms. I don't want you to think that I'm telling you this horribly sad story and it's just this bone of contention in my life. It is certainly not, and it's something that I dealt with. I am a school teacher, and so I teach 8 and 9-year-old kids all day. I have 22 darlings every semester, every year. Those are like my kids. And it turns out that my husband is terrible with children, y'all. He's really bad with kids. And so I joke, but I just don't know what that would have looked like for us to have been parents to our own children. And we did marry later in life. So I do believe that things work out, but I had shared this conversation with Danielle, and she said this is a perfect introduction to what I'm going to talk about. And the last thing that I will say is that nobody thought, my doctor didn't think about me being sexually active as an adult. And so he neglected to have the suggestion of tying my tubes while he was doing the procedure. And so whereas my period was eliminated, then the need for contraception did not stop. And so still I have to take birth control pills to prevent a fertilized egg and the dangers that come with that. With having no lining of my uterus. So that lack of vision that my doctor had is definitely is a concern. And so I'll turn it over to Danielle to talk about her level of expertise with all things sexuality and disability.
Thanks, Angela. So I am a clinical psychologist, and like Angela, I have SMA as well. And I hear about these medical experiences from a psychologist standpoint. So Angela's right. Unfortunately, this is a very common experience. Um, and many a story I hear about how my patients have been to doctor's offices, and it's always when sexuality is addressed, or for that matter not addressed, which I'll get into. So just to clip, many of my patients have SMA, but a lot of my patients have other disabilities, and or identify as having no disabilities. So just to give you guys an example. And so the stories I hear, usually the ones where it's the one where I have several clients in their 30s and they go to the gynecologist for the first time, which again, that's kind of eye opening, because your sexual health shouldn't be addressed for the first time in your 30s. And the doctor says, you know what, I'm not going to do a full evaluation. We don't need to go, up inside, because that's, I'm not going to put you through that. Why? So then they call me hysterically crying because, like, any preconceived notion they had of not being able to have sex was just pretty much validated by a medical health professional. So that's one of them. And it's desexualizing and intimidating and uncomfortable, and for no reason. So another patient just told me this story a few days ago, where she again was seeing the psychologist for the first time later in life. Well, actually, I think she was in her 20s, and she had to bring her mom and her dad into the exam room because the exam room wasn't exactly wheelchair accessible, and she needed both parties to help her be able to stay on the table. So I want you guys to think about that for 1 second. Imagine if both of your parents had to come into your gynecological exam for the first time. And why is that even necessary? Why did that even have to happen? And then finally, there's another story that sticks out in my mind is someone who was told early on that due to the bone structure of her pelvis, she would be unable to have intercourse. And so we talked about how do they know for sure? And she said that there was no like X-ray or CT scan done, that the doctor just kind of felt around and said, yeah, you won't be able to have sex. So, you would think that some follow-up would be ordered, because this is devastating. We're still working on kind of overcoming this trauma and getting her self-esteem back and getting to a doctor that is wheelchair accessible, or accessible just overall in that matter. So not just physically, not just this scenario or the exam room being accessible, but for everyone in this meeting, in this symposium today, having an increased awareness of disability and sexuality will help our accessibility and access needs a million times over. So I'm going to go over a few things. Like Angela said, this is a huge topic. So I started in on the gynecological aspect, but in general, the lack of awareness and education about sexuality and how it's involved in disability is palpable. There's just not much out there. And this is kind of odd because, you know, a lot of our other needs have been addressed. Like we can go to college and it's accessible, and we have housing that it meets our needs, and home attendance. But when it comes to dating, relationships, and sexuality, this topic remains essentially unaddressed. So slide. So with this comes a lot of stereotypes, and I'm just going to go through a few of them. So these are very damaging stereotypes, and they're perpetuated, and I feel like they're perpetuated in the doctor's office because, and this is not to scold anyone, or this is just in general an overall lack of awareness, and it's in our own families and it's in our friends. So it's pervasive. So that's what we're here today to talk about. So some of these big heavy hitters are asexual, fragile, physically unattractive, not able to have sex, not interested in sexual activity, at a great disadvantage in the search for a romantic partner, unmasculine, unfeminine, weak, dependent, and infertile. So unfortunately, I feel that they're still, I mean, they're not as strong as they used to be. We're always making progress, so that's good, but progress continues to still be made. Because as a result of these negative stereotypes, there's a lot of negative consequences. Slide. So, like I said before, they're not just in the gynecologist's office, but they're on the mat of a physical therapist's room. They're in sessions of a mental health professional who are not familiar with these topics. And so some of these are, and Angela touched on this, kind of, I mean, excluded from sex ed is the first one. So we're less likely to be educated about sexuality and relationships. So I think Angela's experience is a perfect example of how not all the dots were connected here. And we also, we have fewer sexual experiences. And also on that note, more healthy or negative sexual experiences. And you could see why, because if you're not educated about sex and nobody talks about it, and then you encounter an opportunity to have a sexual experience, it can be very tricky. And when compared to the general population, we often wait a long time to begin dating and to have our first sexual relationship. We're less likely to get married. And I'm sure you guys have already been thinking this, but with all these negative stereotypes, of course, we have increased feelings of loneliness, depression, isolation, and anxiety. And I think those calls from the doctor's office just really illustrate that, just kind of almost utter despair at times. And this is totally unnecessary. And finally, obviously, mental health is tied to physical health, so poor physical health. Slide. So people are taught from a very early age that one could or should find a person with a disability sexually attractive. So I really like this quote because some people believe that the lack of ease that able-bodied people have when it comes to this topic, sexuality and romance, is conveyed to people with disability. So, and just further increases our feelings of not belonging or being different in that area. And I really agree with this quote. Like, people are taught from a very, very early age that no one could or should find a person attractive, because even if a person does find someone attractive with a disability, their friends or family they can get pushed back in a lot of areas. And from the family and friends, it could be, dude, why are you, well, you can be with someone who has a lot less problems. I don't get it. Or that's strange. And so the stigma goes very far and very deep. So um, what can we do about this as medical health professionals? So how do we defy this quote, and how do we encourage sexual wellness in our patients? And this is like a hot topic. So I talk about this a lot because people in the beginning are like, oh yeah, thanks for bringing that to our attention. Like, it makes total sense. Like, of course you guys are sexual too, but what do we do? Like, how do we fix this or make it better? And so I'll go over a few things. Um, but first and foremost, I want everybody to take note that please take this sentence out of your vocabulary, that it's going to take a special someone to date us or marry us, because that's such an overplayed statement, and it's so horribly wrong and damaging. So it doesn't take a special someone. Well, actually, it takes a special someone to date any and all of us, really, right? So disability or not. But let's just remove it in general from our repertoire. And with that note, so I don't want everyone to feel like they have to tiptoe either, because a big part of having this conversation is to be willing and unafraid and direct. So don't skirt around it, or don't waver. Just be willing to talk about it. And I think overall that's a problem that's difficult for us, because in US society, it's just not so spoken about sexuality as compared to, let's use a country like Australia, because there's a wonderful documentary out there called Scarlet Road, and it's about how sex workers have formed special organizations to specifically work with people with disabilities, and it's destigmatized and talked about, but that's not the case here. So in general, it's hard to, I feel, kind of ask those questions about sex, but we need to remember that people, let's say people with SMA, have the exact same sexual needs and desires as the rest of the population. And for that matter, all disabilities, let's just put them under that. They have the exact same needs. So you would just talk to them, your patients with disabilities, like you would talk to anybody, all your other patients. That is the biggest takeaway from my part of the presentation today. Okay, slide. So self-esteem versus dateable self-esteem. This is something that I came up with as I was doing my campaign to talk about sex and disability, which really, really quickly started when I always wanted to talk about it, and it came from my own experience of feeling left out of the dating world and not really knowing why, because I felt like I had the same to offer as all my friends, but I wasn't getting the same amount of like male attention, if you will. So I started to write about it, and then one day my friend told me about the Miss Wheelchair USA pageant, and I thought, oh great, I could use that let me try and win it, and use that crown combined with my PhD and really start opening the door and talking about this. So that was the beginning of a very cool journey. And I talked from the very beginning, even at the pageant, I'm trying to remember that, about the difference between self-esteem versus dateable self-esteem, because, and I think Angela could totally agree with this, but I wanted to separate the two, because as adults or teens with SMA, Angela and I, we probably had, well, I had, and I'm pretty sure Angela did, had high self-esteem when it came to a lot in our life, our careers, our education, our friendship circle, our families. We had lives, social lives. We were most likely, Angela's doing very well in school because people with SMA are smart. And but when it came to dateable self-esteem, or how you feel, how you look at yourself when you're, entering the dating world and trying to get a partner, that's where you can see it plummet. And often feelings are, our views, our self-worth, it's pretty much in the gutter. So a lot of times from my clients I get, but why would anybody want to date me when they could get someone who doesn't need a vent, or doesn't need this or that? And so that echoes all toward the beginning of my presentation with the negative stereotypes, the embedded ableism about sexuality in our culture. So self-esteem and dateable self-esteem are not directly proportional. So high rates of self-esteem do not equal high rates of dateable self-esteem. And I would say the majority, I would say in the beginning, or if you haven't worked on it in session, maybe, or with a professional, 99.999% of us have low dateable self-esteem, no matter what the disability is. And what's interesting is I was presenting, I don't think I told Angela this story, but I was presenting at the Apollo one time in Harlem, and it was actually an audience not identifying as having a disability per se. And this group of maybe able-bodied 20-year-old girls came up to me afterwards, and they were saying, oh man, that's me. That's me. I have high self-esteem, but my dateable self-esteem, it's really, it's so bad. So, this is a universal thing that we're talking about, just like sexuality is a universal experience. Okay, slide. So just two ways to build dateable self-esteem, because we just don't have the time to get into much more. So you as a health professional can help your client do this. So you're acknowledging their sexuality and them as a sexual person. And at the same time, you can help them out with rejection and developing a thick skin, because another takeaway here is dating is tough for everybody. So not just my clients with disabilities talk about feeling like nobody likes them, or they can't take the rejection anymore from online dating. So it's important, everybody has to get comfortable with it and develop a thick skin. And I think for disability, the go-to is, oh, I got rejected. It's my wheelchair. I know it. It's SMA. I know it. It's my disability. I know it. But that's not the case either all the time. Maybe it is sometimes, but maybe it's also your personality or whatever. It's not just a match for that person. So it's good to get that out of your head, that it's always about the disability. And the second one is to build a sense of control. So it's great and I work with my clients about this, kind of the locus of control theory, that it's not just the universe that has power over you, but you have power over your own life and can help navigate yourself through this universe the way you want to. So so you can take control of your dating life and be proactive. And that's important, because I tell my patients all the time, I can guarantee that you're not going to meet anyone. I can 100% guarantee you're not going to meet them if you're sitting on your couch. So you have to get out there. You have to get back on the horse. When you're kicked down, you get back up, whatever cliche you want to use. And they'll say, well, I don't know, Dr. Shapok, how do you know that I'm ever going to meet anyone? How do you know? And I'm like, well, because I've seen it before. I see it all the time. And there's no reason why you can't meet someone. And they'll say, oh, I don't think so. I don't think so. And I said, okay, but one day you're going to come into session and you're going to say, guess what? I don't know, but like I met someone. And so, just giving people like realistic hope, that's important. Okay, next slide. This is kind of technical, So making health exam rooms accessible. So I put this slide up. It's from NYU Langone Health, the IWD, Initiative for Women with Disabilities. And the gynecological services there only service women with disabilities. So I'll use them as a great example. I even refer clients to them. People will come out of town to go to them because this resource, it's hard to find this resource everywhere. And for example, they have Hoyer lifts to help put the patient on the table. So you don't need both parents and all your cousins to help you get on up there. And I think Hoyer lifts, though, should be in all, medical offices. Larger exam tables they have there with padded straps to hold your torso on there. And the stirrups are very big, padded, have big straps, so people can lay there and be comfortable. Because how can we achieve sexual health and wellness if the patient can't even get into the exam room? So feel free to pass this around. Slide. So I put this one up as kind of a wrap up to my part of the talk. So because this was a big part of my my campaign, was when I got to talk about this during a TEDx, and I did research on this, and before I prepared my talk, and I found nothing about disability and sexuality. So this was a very important milestone. And because the misconceptions that we talked about, the dearth of conversation, the lack of accessibility can almost produce this unsurmountable obstacle. And it's just unnecessary, and it's our duty and as health professionals, and totally doable, to remove this obstacle and help our patient move forward. So I think that, and I touched on this in my TED Talk, what's interesting about it is that this is, like, if you think about it, about having this conversation, it helps everyone, because it's not just those of us who date, love, marry, and are intimate, but it's everybody else. It's all of you guys in the audience who don't have a disability per se, or maybe, who date us, love us, marry us, and are intimate with us. And that's a great note to turn it over to Angela. 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 Angela, are you there? I think we have a technical problem. Let me see if I can fix it. I think you in the audience can unmute yourself. Can you see Angela?
She's frozen.
Okay, thank you.
This is Tina. Her computer's frozen. She's coming back in.
Okay, great, thanks. So while we're waiting for Angela, does anybody have anything they want to say? And don't feel pressure, because we have a Q&A at the end, so we can take some questions there. I know it's kind of a lot to take in, but it's really interesting. Oh, okay. So I think that, yeah, it's a very interesting topic, and there was something else I was going to tell you guys. Oh yeah, so my patients seek me out for 2 reasons: problems with dating and wanting to be sexual and don't have the opportunity, and number 2, problems with home attendants / caregivers. So these are by far the top 2 problems in the disability / SMA community. So
I'm back. Can you hear me?
yes. Hey, Angela.
gosh, y'all, I teach literally every day virtually and my computer never goes out. And as I'm hitting next slide, it went, and I'm so sorry. I apologize. Thank you for filling in for me for a second. And I will run this slideshow now. I apologize. So the art of asking for help. And I think that this is something that I have mastered in my lifetime. And I believe 100% in its connection to emotional well-being. I feel that if you can ask for help in all aspects of your life, you can truly be an independent person, and that independence leads to emotional well-being. So I just want to kind of talk about several. I'm so like shaky because I can't believe my computer went out. Okay, I want to talk about these next few bullet points. The first being independence. And I think that in our society, when we really think of somebody who is successful, and from an able-bodied perspective, we think of someone who leads this autonomous life, right? They have their own, they have a career, they have an apartment, they have a house, they have all the things that people usually gain by being independent alone. And the reality is that that sort of autonomous behavior doesn't exist in the SMA community. We have to have a village to make it happen. I sincerely have 8 different caregivers that work for me at any given time in different shifts. It truly takes so many different people to live a life of independence. But understanding that independence doesn't mean that you're doing it by yourself will help your patients gain the independence that they so desire, because it's a bottom line, it's a goal, it's something that everybody strives for. And as long as they can have an understanding that they can have independence no matter what type of SMA they have, then that leads to the ability to do so. The idea of being able to ask for help really begins at diagnosis. And I'm so happy that I was able to listen in on the session earlier, because I got to hear about how people are having young teens with SMA talk to the doctor by themselves. And I think that's awesome, because it's so important that you can communicate with your healthcare professional. But I also think that it starts even younger than your teens. But that very first moment of diagnosis, when you are visiting with a family, already getting that idea in their mind that they're going to have to ask for help. One of the questions that somebody asked earlier was, do you have a lot of parents that kind of push back when you're helping your patients transition? And I feel so much that if we start the conversation earlier about the fact that they're not going to be responsible for the care of their child for the rest of their lives, that pushback won't happen as much when they're teens. If you, from that very moment of diagnosis, can already start talking about this village and this idea that if we ask for help from other people, that we can build this level of independence already in our patient's mind so that they can achieve it later on much easier. Encouraging caregivers. And I was thrilled when I heard the young lady this morning talking about her mom brought in caregivers when she was in high school. I cannot begin to describe to you how nerve-wracking it is for a young person to have somebody else take care of them other than their parents. And typically the first time that it happens, and for most of us, and in the conversations that I've had with my peers with SMA, is MDA camp, and when they go away and they have a camp counselor take care of them. But that's only for a week, right? And they're forced into it because here you are in a new setting and you've got to do it. But bringing in a caregiver into your home as early as possible can alleviate that stress of nobody being able to do it right but mom, right? Or the only person that can lift me really comfortably is dad. So as much as a financial burden that it is, even if you encourage your patients to hire caregivers, even for an hour a week, 30 minutes a week, whatever it is that they can afford, or perhaps they can already get onto certain organizations within their state that will pay for caregivers. I think that is such an important step. Even now, I have certain caregivers that will be with me for several years and then they're moving on in their lives. And I even get a little bit of anxiousness of, oh my gosh, but she puts on my jeans so well. Is anybody else ever going to be able to put on my jeans like Ruth can, right? Like that's even for me, who's had caregivers since I was 18. But I so wish that we would have known to bring in caregivers earlier, because I think that the mother-daughter and then that dynamic, and I can't speak for men, but perhaps it's the same. My mom and I fought like cats and dogs. And I have an amazing mom. She's wonderful. But as a teenager, when you're just dying for that independence, having the ability to have someone else provide care, I think is just wonderful. And it's a great way to start learning how to ask for help. Self-advocacy, and that certainly goes to every aspect of life, but certainly in a doctor's office, being able to verbalize what it is that you need. So I would encourage you so much to, as early as you can, speak directly to your patients instead of their families, so that they have that verbiage and can develop a sense of being able to talk to doctors and self-advocate for the things that they need. Community. Wow, just the fact that we're all online right now on Zoom speaks to the ability to communicate with each other in big ways. And I think that having Cure SMA, having the Muscular Dystrophy Association present to you today is essential, and it's essential for you to pass that along to your families as well. Just last night, Danielle and I were talking about some caregiver funding and discussing that and how important it is to have somebody else who gets me, right? I just value my friendship with Danielle so much, because she's my age and she knows exactly what it means to be an independent woman. And so we can collaborate and bounce ideas off of each other. Your patients need that from day one. Their families need other your families need other families that they too can say, oh my gosh, can I please just vent? How important it is for our emotional health and well-being just to be able to vent. Because I can tell you that none of my other able-bodied friends, as much as I love them and respect them, are they able to really 100% get my life. And so that community of having other people with SMA, either virtually or face-to-face, whatever that looks like for your patients, encourage them, please, to get involved with an organization or a social media outlet where they can have peers. Finally, managing expectations. And really, it's managing expectations of hope, right? Because in 1979, when I was diagnosed, the doctor basically told my parents, here's your kid, here's what's going on. You're going to do a good job, just try your best, right? That was kind of the, okay, here, we don't really know what to do. We don't really know what the future is going to look like, but just do what you can. And the reality is that all of these new drugs and treatment open up this idea of hope and a future in a whole different way. And so I talk so much about how SMA, we have to be planners, right? I literally know what time I'm going to the bathroom today, tomorrow, and probably for the next month, because I have to plan out my schedule so precisely. And I kind of live life day to day, but in reality, you as physicians can be thinking about their future and the long term, because this idea of the hope for a future has expanded so much wider than it ever has before. And so yes, planning from day to day is key, but also having that hope for the future is absolutely the best way that we can have social and emotional well-being, how we can be able to ask for help. All of those things encompass this grand idea of hope now that we have so many treatments available. So yes, perfect timing. We are going to open it up to Q&A. And Danielle, I'm going to leave it on the screen. So if you want to go to Huva and see.
Yeah. So I'll read. We have 2 questions in Huva, but again, you guys can unmute and ask us directly too. So so the first question is, I've formerly worked with an OT who is great at helping individuals with the mechanics of sexuality. So we brought up the aspect of patients' lives frequently. Currently, our clinic really doesn't have this expertise, so it's hard to start a discussion for which we don't have means to assist. Are there resources online or elsewhere that we can readily use if we aren't equipped? So I'm guessing that. So my question to the question is, what do you mean by equipped? So did maybe the OT, I'm guessing, gave some seminars um, or and talk directly with clients and talk to them about dating with a disability, maybe, or protection or things like that. So there, I mean, I so it sounds so self-promoting, but I'm one of the resources because a lot of my patients say, and to Angela's note, that they want a therapist, a psychologist with a disability or who uses a wheelchair, because it's really hard to know what it's like to walk in our shoes if we don't walk in our shoes. So that's one thing. There's just such a lack. I mean, I also speak to groups with like parents of adults with developmental disabilities, and there's no idea where to start. So we need more online resources. But for example, IWD at NYU is a good resource. They have groups, they bring in speakers. So I guess I would recommend that. Bring in some speakers to present on the topic. United Spinal Cord at Mount Sinai has a sexual health symposium, and I remember going to that, and they brought in this guy who developed sex toys specifically geared toward people with disabilities. And I remember he put up a sex swing, and all the PTs and OTs got in it, and it was really like fun and open and great. So look online and bring in experts like that to talk about it. It would be great if they had disabilities too. So let me move to the next question.
Hold on, Danielle. Someone just asked on the chat on Zoom if you could repeat the name of the resource at NYU.
Yes. So do you want to put up that slide, Angela, actually?
I can, definitely.
My second to last. So it's the Initiative for Women with Disabilities. So IWD for short. And it's part of NYU Langone and Health. I copy and pasted the gynecological care part there because the top part, the front page of the website, has so many other resources. Like you can see on the side, find a doctor, medical services, wellness services, programs, workshops, and classes. And I gave a presentation there about dating and sex, and there were a few teens that came forward at the end, and they said, look, we want to start dating. How do we get around our parents? We still live with them. They think we don't like boys at all, but we do. So how do we tell our parents and start dating like our friends? So there's just so many questions. And yeah, so this is a great resource. Okay, so I'll move. There's another question. Angela, just interrupt me again if okay. I'm just perusing through for time's sake. At what age do you start to talk about sex? In the multidisciplinary team, who would be the best to talk about this? Social work, nurse, as everyone is busy with their role. Most clinics don't have a psychologist. Okay, so if we're talking about a clinic that's services people with and without disabilities, the big rule of thumb is whenever you would start talking about it with a client without disabilities is when you should start talking about it with your client with disabilities. However, if this is a clinic solely for disability, I think we could use the same rule of thumb. Like when do people go through puberty? When do people start developing crushes? And that's early. I mean, I remember at MDA summer camp, everybody was already hooking up, and that was the fifth or sixth grade, sneaking into the boys' cabin and stuff like that. So the earlier the better, and you can't go wrong. Like, why not talk about sex? It's not like you're, encouraging it in a bad way, but it's just education. And that's it in terms of, oh wait, okay, oh wait, hold on, there's a lot more than I thought. Okay, let me just, okay, here's another one. How do we as clinicians approach and support parents to help give the sex talk? That is difficult but necessary conversation as part of the transition process. How would you approach this process for patients in the transition process? Any resources? This is a complicated question because parents are very essential in different ways, and even home attendants, because the big thing I see in sessions is patients who are, have gone through puberty, are feeling sexual, and, right in like Angela did at the beginning, they want to masturbate, they can't use their hands, they can't do it themselves, they're sexually frustrated, who to ask. And some parents will come into sessions, like the moms, and be like, hey, I don't mean this, I'm trying not to sound weird, or don't take this the wrong way, but I want to help my kid do this, and they're okay with it, but how do we do this? And same, some believe that this should be part of what a caregiver or home attendant, just part of another ADL, or activities of daily living. So prepare dinner, clean the house, charge the sex toy, you help them position it, but it's a tricky topic. So, okay, so going back to the question, support parents to give the sex talk. I think a lot of parents have a hard time in general talking about it. It's almost like they need to be coached first and then talk about the sex, do the sex talk, because I don't think even with able-bodied kids, it's hard. So I would educate the parents in the same way, just like I told you, I talk to parents with kids with developmental disabilities, have conferences dedicated to talking about parents. And I think it would be a great idea to have a conversation with caregivers, all the caregivers who wanted to attend, to talk about that. So it's just not a lot of resources. Everything is still up and coming.
Danielle, we've got about 1 minute, just so you know.
Okay, so do we want to just open the floor then, just in case there, anything else? Okay. All right, well, since.
I'd like to ask a question. I mean, a lot of the people we work with would really benefit by working with a therapist or counselor that has a disability. And, we can find a few, but I mean, people aren't generally listed that way. And so I don't know, is there any kind of organization, or are there increasing resources nationally? I mean, using the internet or whatever for this community?
That's a good, very common question too. So it seems like people with SMA or other physical disabilities are starting to become, there's more life coaches I see out there, but there's a big distinction between, mental health in education level between a psychologist or MSW and a life coach. So I just strongly recommend that you're aware of this and you tell your clients about that. But if there's no specific resource per se that I know about, but if you just Google psychologist and disability, but a lot of people that find me are like, I can't find anybody. Do you have room? So I encourage, Angela and I encourage everyone to reach out to us. Here's our contact info. If you can't write it down quick enough, screenshot it. And you can contact us anytime. And I'm quicker at text than email. I see my text more quickly. So if we didn't answer all your questions or I wasn't specific enough, just reach out to us.
Thank you, everyone.
Mm-hmm. Thanks, everyone. It was fun.
Oh, thank you very much. That was great.
Yeah, have a good rest of the conference. I look forward to hearing from you guys.
Thank you so much, Danielle, Angela. It's nice to see you.